Sí, por favor.
And yes, please, we invite you to celebrate or share the declaration. Pardon, I forgot the protocol, the declaration. Could we all rise? Today we're celebrating this International Congress hosted in Mexico City in this beautiful venue of the Inter-American Conference on Social Security. Now we celebrate at 10:06 a.m. of the 12th of September of the present year 2024. I declare the inauguration or opening celebration of the first International Congress of Approach amongst many disciplines to tackle breast cancer now. Thank you all.
Muchísimas gracias, maestra.
Thank you all very much. Thank you, Professor. Please remain standing so we can listen to the national anthem of Mexico City, of Mexico. To conclude this opening ceremony, we thank once again the presence of all the experts that are following and the special guests. Please remain seated just so we can take the official photograph.
Muchísimas gracias por
Once again,
acompañarnos
thank you all
nuevamente.
very
Invitamos
much
a
for
los presentes
following.
a
So we
tomar un coffee
invite
break establecido en el lobby de
those who
este
are
recinto
here
para
to enjoy coffee
posteriormente
break
iniciar con
established
la
at the lobby
conferencia
of this
magistral
venue.
Panorama
Then we're going to
Nacional del
begin
Cáncer de Mama en
analyzing
México,
the national
evaluación de
landscape
lo
of
que
breast
hacemos y lo
cancer
que
in
deberíamos
Mexico
de
and
hacer a
analysis of
cargo de
what
la
we should
doctora
do.
Alejandra
It's going to be led by Ms.
directora del
Alejandra
programa de
Armengol
cáncer de la
Alonso.
mujer
She's
en el
the lead
Centro
of the
Nacional de
program
Ginecología y
of
Salud
the Gender
Reproductiva.
Equity Center
Tengan todas
and
y todos muy
Reproductive
buen día.
Health. Now, thank you all very much. With her conference or presentation will commence after the break. of approach tackling breast cancer. Now, today is Thursday, 12th of September. So we're gonna celebrate the opening of the conference called General Landscape of Breast Cancer in Mexico, Mission and Vision of What We Do and What We Should Do. We're going to invite Ms. Alejandra Armengol Alonso, representing the National Center for Gender Equity. She's an oncologist, thanks to the medical school, Salvador Subirán. She also has her field of expertise is medicine. She obtained the International Development and Educational Growth from the Cancer Foundation and the American Society of Clinical Oncology. Besides this, she's working with the National Institute of Breast Cancer. Okay, Ms. Armengol, ma'am, the podium is yours. Thank you very much. I thank you all very much for inviting me. And I know that there's a lot of people following the streaming online, Nora, and I congratulate you all for making it all happen. And I thank you on behalf of the Undersecretary of Health, Mr. Lopez Huidobro. He couldn't be here today. And on behalf of Ms. Varela Chavez, my higher up. This is a beautiful venue. I hadn't had the chance to be in this venue in the Inter-American Conference on Social Security. Well, we thank the host entities and authorities, Mr. Álvaro Velarca, and I thank ISTE, or the workers of the state in Mexico. I acknowledge you. Thank you for your invite. And thank you for coordinating all the effort. I know that the administration of this major Congress takes a lot. I thank you, also Berta Maria Luján. So I keep record of all the kind words of Dr. Anela Arellano Tejeda, who was at the podium prior. I know that what you said had to be said out loud in each podium, wherever we are, where we're contributing. And I thank Luz through Karen Berlanga and all of you. I know that you're all working hard to protect women's rights specifically. Let's not wait 80, 82, or 81 years to have tangible, immediate, affirmative actions, to protect women's rights and health in general and reproductive rights. I know that we're off the agenda. We're a bit delayed, almost an hour of delay. I prepared my presentation. It would have lasted an hour, but I'll try to be as succinct as possible for you all. So next slide. I'll start today's, or my participation today. I don't have a clicker to change my slideshow. So let me start this conference by storytelling the following, because I've been a doctor. I've been a storyteller since I was a child, and I'll tell you and I'll comment the following. Those who are anthropologists and analyze our societies, or are in the field of anthropology, but in the medical field, or who understands basic economy, would know the dilemma or the tragedy of the commons. If you see in this image in the graph, there's two people. They're like herding their sheep. They're shepherds, and they're taking their sheep to the field. It's green, and these people, or these shepherds, live through the collective activity, and that collective activity is part of is where they collectively take their sheep to eat in that green zone. And those are all the tools that these people have to use daily. At the beginning, the two shepherds are in agreement. They know that both should have the same number of sheep, because the resource that's there in the center is finite. Remember, the system, the healthcare system, has also finite resources. This is a classical example and analogy. Next slide. But what happens if you use your reason or judgment at an individual scale? You can say, okay, I need to have more income, more revenue, more resources. And what happens to my neighbor, the neighboring shepherd, it doesn't matter. And when I was driving today towards the venue, and I was queued in line to go to the second tier of the main highway in Mexico called Periférico. But at the end of the day, when people cut in line and cut you off to go to the second tier, it just affects you all. It's the common analogy here. You see the number of sheep that are increasing, but they don't have that common ground or that green grass that they fed from. And without that common well-being, that could trigger trigger other activities that affect individuals or the shepherds, it also affects the community, the collective. So it's clear here, and in our findings, we see if at the center there's no green grass to feed from, then they lost the resource, that common asset. So there's no way in general. So could you fall back one slide, please? Thank you. Next slide. Now, considering that case, you'd say, if you analyze this, you say that's so easy. Just divide the green grass, divide the field, the shire or the hill, just divide it, give half and half, half to each one. So let's act like Solomon, like King Solomon, and just half and half, right? So if one side ends or is no longer has green grass, it's like the private entities, and that won't affect the collective if you're thinking about the private network. But in this side, you see in this slide, the grass is not divided equally. The shepherd to the right that's at yellow has a bit more of green grass, but the other one doesn't. So it's like then you negotiate and start analyzing how to obtain a permit to get more of the green side to the other side or more green grass to the other side under negotiation and settlement. What happens in the next slide? The tragedy of the commons is the following. Ownership rights or asset rights or the common collective rights, it's not well defined. The theorem of Quaset and the economic theory of the traditional rights over property or assets are the following. The solution is in the definition. When you define the rights you can use to exercise right over assets. But if you are mindful is how do we draft or outline private law and the right, like how do we divide the air, clean water, fish, how do we divide that that's collective, or even public health, how do we divide that? I don't have an answer to that common question, but how do you divide the common well-being that's implicitly part of health for all? But that I haven't found a way to answer that question. But what is true is that we must all explore the paths, the feasible ways. That's what we exactly should analyze. We have to all have the best position or stance to be capable of protecting the users and beneficiaries of the public health care system. When we have been defendants of users and beneficiaries that have access to the healthcare services, I was working as a defendant for those users of beneficiaries, and I couldn't just be there 20 years analyzing, filing complaints, because I can see the stages of breast cancer that no longer have cures at different stages. So I point out in my case files, and we all need to learn. At an individual level, all public servants have their obligations. News for you, we are all public, we're all servants. We have to have that in mind. All our actions and the lack of defense, if we're not fighting injustice in the healthcare system at what we observe in this country, you have to, with sound judgment and reason, then take a stance. That's a brief part of my story, but next slide, please. The dilemma of the collective, that collective asset. And look at this. There's 3 women that were awarded like the Nobel Prize in economics. The life of the 3 laureates of Nobel Prizes are very interesting. Then we have Dr. Alstrom, the theorem was all individuals are judgmental and reasonable. They will only execute their judgment based on what they studied. So she studied communities. This doctor noticed that that's not true. Community or collective institutions, bottoms up, can create solutions for common problems. The lack of social equality affects building our institutions, but we can design schemes or joint plans between economies or states, local communities, and international communities. Next slide. That's why we're here. And Dr. Ostrom is so smiling. She wrote her dissertation based on data of the last century, in which some hypotheses specified that what she submitted could not be possible. She's a politologist. I hope you can read her bio. You can access her bio in internet. Next slide. In this next slide, if we speak about the role of women in work, we're all working for inclusion and broadening our mission, our vision. And with the next slide, I'll show you. There's 3 women that received the Nobel. The last woman that received the Nobel was Miss Claudia Goldwyn. Claudia Goldwyn speaks about the fact that poverty has a face, and that face is the face of a woman, because women don't have land nor resources and analyze her instruments or documents. So it's very interesting what Ms. Goldwyn wrote. It's very interesting to see the story that replicates and echoes each one of the points on the slideshow throughout my narrative. Now, we all know the scope or magnitude of the problem. We all know which are the trends throughout time, forecast trends. How do we build public policy provisions, and how do we take these laws into our institutions? Which are the grounds or basis of law? Why does budgeting has to be strategic? Quality is mandatory in all the steps of the process. And I'll share some results with you. I've been 3.3 years, 7 months in my position as a post holder, an incumbent in my unit. And I've had to face two problems: a pandemic due to COVID-19 throughout my administration, and the process of the federalization of well being. This chart shows the death rates in our country. In Mexico, we have robust, solid, objective data, and we have death quantifications here in the chart. We've measured cancer. To decide public policy, we have to consider death rates and the number or incidence of deaths. Mortality measured back in 2018 to 2022 is there in the chart. We have quantified the rates. The death rates there, it's not the same, it's incremental. It's very important to see the chart. 22 women daily died due to breast cancer in Mexico. 22 women die in Mexico due to breast cancer. That should be enough reason. I mean, systematically, the system has failed Mexican women. When we treat cancer in general and breast cancer, when we detect cancer in the right stage, you can still treat it and cure it. I mean to say, the lack of justice in the healthcare system is there in its material. When there's an avoidable condition, we can react, or there's a method and a treatment. And then the third point, I mean, if the person or user has access. Here in the chart, we have the stages, and you see the green color in the chart, but death rates at a national scope are here. I mean, it hasn't really changed in a 2-year term. You have the data of 2018, 2022, so it's almost the same, 19.61 per 100 women, and the northern states are there listed in the state, in this country. They're the countries that have more cases. Colima is at the center of this nation. It gives you a clear example of what's happening in Colima. There's so many women dying in such a short period of time. Next slide. This maps out in color codes the changes between 2018 and 2022, what you all know. So we know that this was all submitted. We analyzed what's happening in the northern state entities of their country. We've analyzed the life conditions or well-being of the people there, the population, but it's also a problem in the center region of the country and in the south cone of this country, in Mexico. One of the things to decide how to draft or word public policy or general legislation is, throughout time, we have to see the trends after 1-2 years, and you say, okay, this is what's happening, this is true, this is material. What we have to review or analyze is what's happening throughout time, the behavior of things throughout time, and mortality or death rates throughout time. We see the trends forecasting being measured. You see the arrow in green. You can see the measured increments based on the measurements of 2012 and 2020. This is the analysis of all the healthcare system in this nation. So we can compare the evidence, and based on the findings, we see what's happening with breast cancer there. This is a tool or a chart that helps us define and word public policy. It's a flag, it's a warning flag, it's a healthcare warning flag. What happens with uterus cancer? And I'm here at the podium speaking about uterus cancer, breast cancer, and cancer. I speak about this in correlation to finite budget. And we have to use and exercise our economy, or what's budgeted, very carefully. Uterus cancer, as it's been said, and it's been said by the OPS or PAHO or Pan American Organizations of Health representatives are there. I mean, think about the numbers. The Ministry of Health, the government program for prevention, that's the oldest program for screening cancer, just turned 50. We screen to timely detect uterus cancer or breast cancer. Those who took my position or had my position in the institution I represent, prior, it's like the Papa Nicolau declined in my institution 50% in this country. So that's a major achievement thanks to the programs of the system. So the users or the patients accepted to be subject of screening and the use of new technology. So the decline of death rate stopped, halted in that time frame. It's stabilized. It's in that horizon, in that plateau, and we're doing things better. This is data that communicates or translates to what's happening in the healthcare system. We're betting on the use of our resources correctly. We know they're finite. We have to obtain the process, the data of prognosis, Paloma, DNA testing, and other tests. So we have to be very precise with the tests or samples so we can avoid or try to eliminate uterus cancer. And this could stop being a part of the use of the budget of the healthcare system if we stop it. What's the public policy? This is a magnitude of the problem. The problems are of this dimension, this size. So we need immediate government action, and those actions should be based on solid diagnosis and analysis and feasibility studies. This should outline the legislation for public policy. We have the citizenship participating. This law gives us the governance model. This is the outline. This is the problem. These are the feasible solutions. Next slide, please. How do we build? How do we build or reward public policy? And this is a live presentation. Click on it. That's why that point is red. It starts at 0 in this chart. How do we have a decline on deaths due to uterus cancer? Next point. We have to draft the proper public policy to achieve that green color code to have a decline on death rates or mortality. How do we reach that green color code? Not just by wishing people well with desiring it, just multiple campaigns, or we don't achieve that. I know that some of you are dressed in pink because that stands out for the fight in cancer, but that we can't achieve this just by dressing in pink. We have to satisfy 3 needs, basic needs. We need resources, we need insurance. I don't know if I can change my slides from the podium because that would be easier for me. Can you give me the control? Next click. Okay, resources, rules, clear rules, sector by sector, that have in the body the minimum requirements so the public policy that's enacted makes it happen. And now this second tier, that it's very important. I left it like this, blank. Who can say networks and networking, creating strong networks or ties are very important. If there's outputs of this dialogue, you say, okay, the keynote speaker or doctor today said that this is based on the 3 R's. Here, you see, it's part of what I'm going to say. It's part of all these models, those 3 R's. The effective coverage in government programs, it's something that we've worked on in this country, and it has been material. I mean, universally in this country, I analyze the numbers. You say, I measured 1,500,000 or 1,500,300 and some more, and you see the pictures of it in print in the newspapers. How that impacts me? How could we have a decline in mortality? We analyzed the mammograms and others, and those who suspected that they had cancer had other tests and results. Those who went through a thorough analysis, they went through a biopsy, tissue sampling with histo analysis of their chemistry, and then you analyze who was given the first oncological treatment for the specific cancer that was detected biologically speaking. That's important in the system. The numeric coverage, get that out of your mind. Think about the objectives, all the missions. Don't interpret it the other way around. I mean, let's measure the efficacy of coverage. We have this model in the chart that's correlatable to quality, the services that are offered, the efficacy of the services offered. So the response mechanisms in the healthcare systems to provide social security benefits, and those should lead us to have an effective, broader coverage. Next slide, please. Could you change to the next slide, please? So public policy, when we draft public policy in correlation to cancer, who who writes it, who dictates, who verbally creates the law in wording physically. I mean, we have three centers that are correlated to the National Healthcare Center. There's public policy and other components in the graph. There's components of sexual opportunity to reproduce. There's other entities of treatment in Senapred, the National Prevention Center, and the prostate analysis. There's public policies being drafted for our youth as well. You see all the graph, but it's not just about writing and wording public law, but guaranteeing that the backbone and all those modules are a part of the law, that we can integrate and provide the services, that we can guarantee that the chain of supply of those services is continuous. So you think, which are the axes of transformation that are part of the program of prevention to control cancer? And that's embedded. There's three axes or three pillars that I mentioned a lot. Precisely. The coverage is, pardon, the approach should not be quantitative. The approach of cancer should be qualitative. Next slide. And precisely that. In correlation to what's the essence, we must guarantee that what's the process of, we have to meet quality standards and the efficacy of coverage. So it's quantitative versus qualitative data. And we see the networks of the services. We have to focus on public policy, cross-crop, interinstitutional, with different sectors, based on agreements, based on findings or evidence, after analyzing the healthcare tools or economic analysis in this field. Very important. Point 3, alignment with the WHO global initiatives to control breast cancer and the strategy of uterus cancer. And those are the strategies. Since 2021, next slide. In 2021, we kicked off the transformation implementing the government program to control and prevent cancer. Next slide, please. Now we're going to speak. Let's speak about budget. Let's speak about resources, money. Two examples. Dr. Oscar Arrieta is the director of the National Institute of Cancer, and he kind enough shared with me the budget to be exercised by a program called Micaela. The National Cancer Institute has this program, Timely, that integrates many disciplines to tackle cancer and metastasis in different stages of cancer. We have to fight cancer. It's a need in this country. I mean, there shouldn't be that progress or advancement in cancer. That's factual. And we have to answer to those who are suffering cancer. The program received this budget to be exercised, 129 million pesos, national currency. And I asked them, and how many new patients receive a physician's appointment when? I mean, it's not just it's very broad. They also in the analysis, no, but there's other fields to analyze, like training. But if we want to measure what's happening with each person receives 185,000 and a bit more pesos. It's 185,213 pesos. You think about budgeting the government program or this INCAN program to prevent and control cancer in the center that I work for. It's federal government budget. It has to be exercised in the chapter 12. It's that's the program. You see, year after year, what has been measured since 2019 till 2024. We have analyzed the variations, but the annual average is 252,756,872 million pesos. So you'd say that national average, that's a lot of budget, right? Wow. But if you quantify objectively the demography, the population that do not have access to social security benefits, there are 25,711,46 women. That's the quantification. I mean, they're my objective. What do I mean? If I convert this, I mean, we invest in one person or in one patient 10.6 pesos. It equals to that. Why do I say this out loud? Because that's part of planning, not of this former administration. Historically speaking, the primary services for cancer patients are considered a segment in which there should not be budget invested in them. As an expert in oncology, I've been invited to talk about breast cancer today, and I believe and I can confirm that that's a mistake. And that mistake has to be solved from the backbone, from the structure. I mean, even considering the budget that's allocated from the Federation, we don't know, we don't need laws or, minutes of understanding. We need budget. And for that, we need the participation of the citizenship, well organized civil society entities. We need other stakeholders, the doctors, physicians, the healthcare practitioners, and all the disciplines in our colleges should not sell their interest to the pharma industry. They have a crucial role, which is the well-being and health of the collective, the citizenship. Next slide, please. What have we done? What have we done? We have a little bit of the budget strategy. Triage is one of the screening methods. Let's eliminate uterine cancer in Mexico.
Position has been able to increase the testing, which is a PCR in actual time. The 32 states that the test is currently for free for you to inform everybody. I know that ANEL has been congratulated, but not the rest of the institutions. And it is the opportunity because Mexico has no longer problems with vaccination. We are reaching the expected World Health Organization coverage of the vaccine. So the BPH vaccination is not an issue in Mexico, and I hope it will not be. But the problem in Mexico is the screening and its quality. So this has allowed us to publish guidelines, and we have a guideline for BPH and women and trans populations about both immunocompetent and immunosuppressed populations. The transversalization of the health, sexual and reproductive health are very important, but the rate of incidence is for every 100,000 women. Now we have almost triple, and that is unacceptable for the national health system, both public and private. What does it mean? The transversal vision means that in all the components of sexual and reproductive health, it is not a program. Those of cancer take BPH, both of Bayern research, and you make line and get your turn. No, let us give women the opportunity and dignified treatment and the respect of their time. So if somebody goes and get a contraceptive and the uterine and the uterus is having an issue, they should have a cytology. The same for breastfeeding advisor, and also the health supplier should ask for the test. So that is a transversal focus and the only one that could eliminate the uterus cancer in Mexico. Why do we need it? Because we need funding to serve the emergency of public health of breast cancer. Next slide. Focus, finance, and making it possible. Next, please. How did I receive the program when I came in 2021? A lot of people came to tell me, what are you doing? Why are you doing it? And the reason, I hope that I made it clear. Everybody of us who for some reason believe, and people call us naive in the fact that hope has not been lost in this country, and we wake up 6 in the morning thinking that we can change the world. And the answer was, why not? Why not? If we are in the worst of the moments, because we are in a pandemic, because a lot of people will die not only because of COVID, but also by breast cancer, specifically breast cancer. And if you see that chart, the area shaded in red is the gap of attention. See how we lose users. This is for the state services of public health, from the screening and diagnosis. See what we need to cover, and we only cover 8%. And like that in the chain of integral attention. Next. How many people we miss? And I always talk about people, persons. Well, I don't like to say percentages, but persons, because every person needs an it is compulsory to respect their right to health. And if you see the loss in every one of the processes was scandalous in 2021. But this happens to all the health systems, or it only happens in Mexico? It happened to all the health systems, the most advanced, the countries in the medium and low and high income. And simply, it takes it a different proportion. If we try to trace the continuum of attention of breast cancer, we would see something like this: diagnosis, screening, diagnosis, early diagnosis, histological detection, treatment, and survivors. Mexico has a historical depth of survivals among women. If I ask how many women here have had breast cancer or know somebody, don't raise your hands now. You would be surprised about the amount of survivors of breast cancer in Mexico. And that is a need that we have. We have urgent needs, the survivors of breast cancer. And that is something that we have not been able, at least sectorially speaking, we have not been answered to give an answer to. That is how we see the system. Next, if we wanted to model how, well, this is not for you to read it, this is for you to have an idea. That is the example of complex systems on health, the example of serious deficiency in the knowledge of the science, the implementation in the application of the science, the decision of public health policies. And I present you the program for specific prevention action and control of changes. I will only present you for you to read it, but I don't want to extend to my time. But I want to tell you that in the program, which is a sectorial program, that is the ordinary IMSS, Bienestar, IMSS, Pemex, Sedena, need to know it. Many times to health personnel, I ask them if they have read that information. And it is important everybody to know it, but it has to do with aspects of primary, secondary, and tertiary prevention, and above all, in an environment of respect to human rights, inclusion, and the quality of life. Next. What progresses have we attained in normativity? I say it because it's a media coverage subject. And it is common that service health providers distinguish the political position that we could have, the government, the administration intern, and the other is a technical position that we should have on breast cancer in this case. As you know, January the 30th of this year, it was decided by the Consultative Committee of Normalization, who are in charge of the official Mexican standards, to have the process of cancellation of norm 041, which comes from 2011. We have delayed a lot. And that of uterus cancer, which is 95. That is scandalous. That is to say, why it has not been updated? That is the question. So the first answer is because the government doesn't want to do it. That is easy to say. Why? Why it has not been updated? And the answer is many efforts have been done in the center that rules the updating of Mexican official standards. Before they have prepared draft of projects. If somebody is sitting here, I thank you. But for 2021, we updated the draft project for 0041 NOM, and we are a controlling group of 51 groups in consensus and in discussion. It was done because I knew it was the need to have an updated standard. In 2022, we said, well, let us continue with the uterus cancer because we don't have a team to discuss both norms at the same time. And it was decided to be canceled. But that is different to say cancel and not in effect. The two standards are in effect, but they cannot be canceled until having a document that substitutes them. It is important when the NOM was canceled, I received 200 calls from three types of people. One screaming at me with poor language, and they would hang. And others would say, isn't that true that there is a Machiavellic plan? And I said, well, I don't decide it. It was decided by consensus, a group of experts of normalization. And the third that I would pay attention to it was, doctor, we have worked 1 year for the draft. How come this is not a word? And my answer was, don't worry, it will be a word. And precisely the technical guideline for the control and vigilance on breast cancer, which is about to be published on October. And this guideline is very important because it has the sectorial consensus of indicators. All the public policy documents which are not in effect are not of interest. Those of interest are those that are compulsory, that are institutional, and that have performance indicators. In fact, session that we finished that for uterus cancers. We have sectorial indicators finally that will be reviewed annually to see what we are doing, what would be the minimal indicators that we need to pay attention to trace the processes of breast cancer. So it is already on, and I say it in a loud voice, but the only way to be trusted is it to be published. So you will see that on the digital website of the center. We don't have money right now for the publication, but in sometimes it will be distributed to at all levels on subsystems of health. The other documents you don't have to read them, but there are very important progresses in precisely in the definition of public policy, and there are agreements in National Council of Safety for the Well-being, precisely so that the state health services now operated by IMSS Bienestar to meet the minimal requirements of quality for everything that you see on the screen. Next. Mexico is ready to have timely detection through mastography in women older than 40 years of age every 2 years in the context of an advanced level of resources. The reason is that we are not a limited country in this moment, but we we had a public policy and we asked if the resources were advanced. Next. What do we do if we have no money? We are creative. I tell this to my teenager daughter, let us be creative. The models of teaching of self-exploration of breast cancer, which are expensive, they are broken, the balloons that were filled with flour to detect the tumor. And we said, who decided that and why? Women? Women have the breasts on, and women can educate each other. So we said, let us prepare a self-exploration workshop live, and Professor Vasquez is modeling our gown, which is made with a fabric used for the uniforms during the COVID, which is a kind of tissue on paper, and see how we got nude from the waist upwards at the office, and nobody would believe it. And in the office of the health ministry, where 1,250 women work, half of them are women. And we say, okay, and why not starting with our example? Why not discovering that the health personnel in the program and that preaches every day, why not? And they sometimes they don't have the time and they don't do it. So we found this workshop. It is a playful of sisterlyhood, where people has tears on eyes of happiness to get the knowledge, and they feel safe, and harmful injuries are detected. We detected 3 tumors in just a few people, all of them in an early stage, and they have been treated and referred to as experts. What I mean with this, we need more resources? Yes. Can we do something with what we do? Yes, certainly yes. What is the gap of the health personnel? As you know, the standard of reference for breast cancer as testing, screening, and diagnosis is mastography. And there are many pressures of saying that mastography is not the standard of reference, but that is a separate story. The problem is that to have this reference standard, we need highly trained personnel to do that. This is what happens in Mexico. You see the gap of doctors and radiologists exclusive for the screening and diagnosis program is in 83%. What did we say? Well, we need to do something. The radiologists are not trained overnight. They need a time of preparation and they need to hold some experience to interpret the mastographies. Next, even more to do biopsies, which is in the role of the radiologist. What we did is that there is not functional equipment and there are not sufficient funds. Let us have an analysis of coverage to see where the users live, what is the functional mastographer, which means that exists that there is personnel operating in a continuous and exclusive shift. Because in Mexico, there is a poorly told history. They saying that there are no mastographers. No, there are no functional mastographers. So that is the truth. So the tracing, the plotting of this reference was made. We had to prepare 3 million screenings. What do we need? So if there is not equipment which is functional because they are obsolete, we need to have a triage. Those are the variables considered to next. And we made the donation of the largest mastographers donation, the largest in history, 45 mastographers benefiting 250,000 women, and they are precisely placed where there is more need of them. So we need other stages, yes, but that is a good beginning for the country. Next, 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 and the next. I wanted to say how the analysis is done, but we don't have time. The other important thing, the quality guarantee of the mastography services has to do with establishing programs of quality control, which are very specific with trained personnel. You see the radiologist technician, radiologist, an advisor, specialized, or a physician, but everyone has a very important role. This is very important. There is not a worse screening than that poorly done, or diagnosis as well. It is very important, the quality. Next. Next, next, and next, because we will not be able to see them. See the next 4 slides, please. Next, 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 that one. What did we do after replacing the equipment? If there is no physicians, let us make the physicians, the few ones we have for the program, to work in the most productive way. The need in Mexico, the need of physicians that we know that there's a large need to move the chain of attention to priority diagnosis, that they are preparing biopsies. That is the truth. The screening, obviously, we have a gap of 83%. In 2 years, we will not have radiologists, physicians. They are in the private initiative, but not here. But why? Because we are not offering them dignified work conditions. Second, let us have centers of reading of distant interpretation. This was in 2022. Everybody told me that this would fail. And when I'm told that, I say, oh, how come? It will not. So there are 3 reading centers in the country, and Chihuahua, Querétaro, and Mexico City, and they're interpreting with the control of the second reading in the states who do not have a radiologist physician. Now, I had a chat on the role of homemakers, and they have us random health. Some of them are good and some are very bad. So many of them are of state-owned resources, but we keep on insisting. In Mexico City, it was never thought that we would need unanimous, dedicated unanimous. That is why they are not in the rest of the country. And that is the lack of planning, not from now, but from many years ago. And it was not thought that in the third level, it didn't have to be the center to discard or confirm the cancer. No, they are not invited. They are only invited to treat and to give opinions, but not to do the screening in Mexico. What was done when this was known? Dr. Claudia Sheinbaum, the first thing I told her, I remember that very clearly, October 18, because after that date, I said, it is not possible, that is anti-human rights, that in Mexico City, if you need a free biopsy, to go to the third level of attention to see when you get it, or to pay 15,000 pesos. That is unacceptable. So I think she heard, and to me, that is a good sign. She heard. There are three centers, two working in Romero Rubio and Salvador Allende centers with the passing of a single day. And I hope that soon will be opened the unit of oncological attention for women in La Pastora Hospital, very close to the limit or in the state of Mexico or where the teleferic is. And I said, oh, well, okay, La Pastora, it's a good term. When I was in nutrition, the patients was like doing shepherding, and it is Catholic. Sounds Catholic because you are doing shepherd. You are keeping your sheep. So I said, this hospital, we have the capacity of the integral circuit of diagnosis to treatment in infusion rooms. The only handicap is that there is not a bunker for radiotherapy, but I think that it is a big initiative for Mexico City, an initiative promoted by Dr. Claudia. And I'm happy when I see that open. I will say something was done for the women in Mexico City. Next, please. I will finish. I will not talk about the subrogation of services. I was about to do that, but it is a very interesting subject. However, I will not elaborate on that. What I wanted to say is that surrogated services has made that this country not to strengthen the state capacity to guarantee the public need. And there are many conflicts of interest, a lot of corruption, and a need in a disease that depends on time. There is the need to subrogate. But where should we go? Well, to not subrogate the services of mastography or integral services. The next and the next. Oh, I would even include the cost. Well, the results. We're about to finish. The results. Mastography of the screening diagnosis and critical stages. A very usual narrative that I have heard since I was an oncology student is that in Mexico, the users are lately diagnosed because the screening and diagnosis system does not work. As if the third level wouldn't be their fault, or more or less, of challenging the first level. And I say, why not? We share guilt. The delay of the user is one, but most of the delay, and Dr. Carla Unger will be here later, that is the system. And that delay is systemic and systematic and absolutely complex to be fixed. But what have we done? As of February 2021, the first indication to all the state services of health was if a woman or a trans man has a mammary symptom of suspicion, pay attention to them and take them to an imaging. What changed? If you see in 2018, 2024, almost 60% of the diagnosed in the program by the health ministry is in the stage of stages 1 and 2. That is an attainment to be published, and this is why you have not seen it, because there is a political narrative and technical, not technical. The publications are like this. They are doing nothing. They do that very poorly. They should do something. And everything is about it. Very important to tell you that we can change the history of breast cancer in this country, and we can change it for a history, even if we don't have resources. Now, what are we working on? It is not only, okay, stage 1 and 2, kind of applause. No, we don't have applauses like Peña Nieto. We don't want to be applauded. We want these people, once diagnosed, to go to the third level of attention with maximal timing recommended by World Health Organization, but not only that, but not having an impact on their survival. I won't rate it, but let me tell you that this is information for 14 states because not all the states participate because that would demand a superhuman process. But we are between screening and first oncological treatment, 49 working days. And somebody could say that it is less, but it wouldn't even exist. The data were not updated. And between diagnosis for symptomatic people to start the first oncological treatment is 18.5. Now we need to prioritize that the patients who enter by symptoms, we are progressing. The next, the data are published in the websites of the National Center of Reproductive Health. That is to say, all mastographies on all diagnosed cancers. Here, there is nothing to be hidden. I say because I received many questions from researchers saying, where are the data? And I say, well, here you can see them. Now that we finish this year, we will include the data for 2024. The next, this is very important. We need a feminist agenda of feminisms for oncology because gender inequality and discrimination influence the opportunities on the rights of women to prevent risk for cancer and prevent the capacity to look for the disease and the treatment of quality for the progress of women leaders in the research in the clinical practice and as me in the formulation of public policies. It is urgent, and this is why I added in highlight a change in the view, in the gender view in the public policies and in the health professionals. When I was told, hey, doctor, why do you want to buy a brush for self-taking? Who has received a cervical tomology? Who did enjoy it? When I ask why there is not a brush which is used in Europe, and the reason is, well, nobody asked for that. Conclusion. We need a view not only of human rights, but a gender view. And remind you that the gender view studies the relations of power that we exert among us to find the best opportunities for equality. It is not only that, well, that Dr. Moreno does not want a man. Well, my husband has his own areas of opportunity. But well, let's say next. So in conclusion, and I did it fast, what do we have and what must and what are we already doing? A public policy which is sectorial needs to be universal and focused on users. Normativity, whenever it is sectorial, and link all the health system. This is what I said. Gender approach, intersectional view on human rights, and with cultural pertinence. Mexico is not Mexico City. That is very important to be said out loud. Mexico is not a woman in Chiapas whose only access to health is perhaps the attention of her pregnancy, and she will never ever receive access to the system. It is very good to think of 32 scenarios, different scenarios, where the public policy is not dictated in the desk, but in the territory with the users, with the health providers. Eliminate uterus cancer. Say it out loud. Eliminate. My colleagues I respect a lot and are of most experience in medical oncology since many years ago. I see them with pride of what they are, but also with concern. And I say, when this is finished, what will they do? I hope my eyes and your eyes see the uterus cancer is eliminated. Well, you will, because those with immunocompromise, it's like C hepatitis. What do you do if you are the largest experts in the complications of cirrhosis? Well, nothing. exactly the same as it has to happen with cervical cancer. Approach progressivity. Every public policy needs to be progressive. We cannot do what was not done overnight. If it was not done in 50 or 25 years. Guaranteeing the diagnosis that includes, obviously, the standard of pathological reference and the specific treatment for the subtype of breast cancer, the quality of all process, and all the units need a systematic assessment and the continuum of the level of quality. And something I invite you to read, what is the National System of Public Health? There is a web page published. For me, it is the hope that we consider, and it is written there for you if you have not read, the cancer screening as a maneuver of the essential functions of the needs in this country that we will have, and in the territory it is already there, dedicated only to public health, and among them we have cancer. Next. I bid my farewell saying that we are a team, that we love each other. At the center, we are less than 25 people, and what we have in excess is the enthusiasm to change things in this country. Some of my colleagues could be my parents, and sometimes I tell them and they get angry because they think that I am calling them elder. No, that is okay because they have chasing a dream after 50 years, which is the elimination of uterus cancer. And I finish with this. I recommend you the book of critical thinking on the health systems in Latin America, which says we need to reintroduce uncomfortable questions on how to produce territories and territorial lists of integral care of health, generate the geopolitics of autonomy, relatives, and spaces of sanitary systems adverse. We don't have excess of resources. That is to say, a tireless search of the collective production of humility. Thank you very much.
Thank you very much. We'll continue with today's agenda. Ma'am, Dr. Mengol, thank you so much for being such a great speaker. Right now, we're going to give you an acknowledgement, ma'am. We celebrate your presence. This acknowledgement is given to you on from ISTE, the National Institute of Workers of the State. Thank you for your presentation, Dr. Armengol. We'll continue with today's agenda, with today's program. We're going to start the ever-growing mortality due to breast cancer in Mexico. It's an urgent call to all the institutions. This presentation is going to be led by Ms. Unger Saldaña. Dr. Carla is a researcher, professor at CONACYT, the National Science and Technology Institute, researcher #1. She's a scholar in econometrics, thanks to the center CIDE. She's a master's scholar as a doctor in health. She's a surgeon thanks to Tech from Monterrey. She's also a professor at UNAM and has drafted many papers like ANSWER, and has worked with the ANSWER Regional for Americas and Netherlands and the Global Oncologic Unit and the US. Thank you, Ms. Unger. The floor is yours. Thank you for visiting this beautiful venue.
Muchas gracias por la presentación.
Thank you very much for inviting me. Thank you for presenting me before the audience today, Dr. Anel. Welcome all. And I apologize because you might have already heard what I'm about to say in this initial announcement. And I hope that what I manifest is useful for all and for many more. But I know that there's some of you that have already heard me speak about these subjects. I'm not just going to speak about the fact that there is an ever-growing need need to tackle that mortality. It's been said clearly in with the previous speaker. So the situation is avoidable. We can prevent. There's so much to do from our trenches in different sectors. Like I have branched out my dialogue with you today into three phases. It's cancer control, breast cancer control in Mexico in the landscape. That's the first point. And I'm going to try to convince you with the fact that the main problem is that there's a major delay or lead time for people to obtain treatment, proper treatment when they live with cancer. And point three, the feasible possible solutions. That's how I break out my presentation. Amongst the first cause of mortality and is cancer in Mexico, so for women. And in the rest of the world, or in the world, we see in pink, it's breast cancer measured globally. As you can also observe in this map, there's many countries in which breast cancer is the main cause of death. What's color-coded in blue has the main cause. The main cause is a different type of cancer, like lung cancer. However, if I showed you the incidence map, you'll see that the main cancer that impacts or affects women is breast cancer. What do I mean to say? This translates into, it's not just because it's the most common cancer, but even if it's the most common cancer, it should not be as deadly necessarily. In many of these countries where women suffer breast cancer, I mean, they don't die. They can survive it and live to tell what happened and continue with their lives. How are we doing in comparison to other economies in the globe? Unfortunately, when we compare, we have to use other sources of data that are pretty old. We don't have any immediate sources of information to compare what's happening at a global scale in all these countries. And there's also first economies in this measurement in the chart being analyzed. In the first 5 points you see in 2004, 2015, there's the pink points. And the majority of these countries measured that are top economies, mortality or death rate has declined in this measurement, which is in decades. That's not the case for Mexico. In this chart, Mexico's cancer cases have increased incremental, and the future forecasting of this cancer leads us to think that it'll increase if we don't intervene immediately. Now, these are countries that are strong economies or developed economies, and what's common, there's common elements in this chart. They've reduced the death rate of their women in 40% since the 90s. So these countries can detect over 60% of cases of cancer in stages 1 and 2. When you staging cancer, I mean, if we have clear goals, irrespective of the tools that we're using to measure or to achieve our objectives, first we have to analyze the chart and see the changes in the trend or mortality. And what has an influence on death rate or mortality due to cancer? Two things influence. How frequently do we observe the disease incidence and the survival of those people that get sick? How many survive it? How many get cured? Let's analyze in this chart the survival data of cancer in Mexico. Now, if you use the source of the catastrophic fund of the popular insurance agency in Mexico, we analyze the numbers of all the women that were receiving services under the coverage in this fund. 52,000 women approximately received treatment in a 10-year horizon. We estimated their global survival rate, which was measured at 72.2%. And you see the stratigraphy, the layers per clinical staging. The earlier you detect cancer in the stage, the better. So we have a decline if the staging of cancer has progressed too much and the survival rate declines. In comparison to other countries, if we compare countries with the American states or OECD, that all these American states have this information available, so we would be standing here as a nation. I can't read because of the letter size, the font size. If we compare ourselves to similar countries, Brazil is highlighted, Colombia is highlighted. We're similar to Colombia, but we're 10% above Brazil. Now, if we compare what's happening in this country, you see the staging, survival per clinical staging of cancer. We have grouped up early staging of cancer, when you pinpoint the location of cancer versus, other stages of cancer, and we measure the survival rate and we group things up and have the ratios with other countries. Now here, we see the similarities that we in Mexico have with Brazil. In phases or stages of cancer, we're measured and the results are more or less the same, but if we analyze global survival for all that were measured, we're under that other country by 10%. Now, what has an influence on the capacity to survive? Three things: the staging of cancer, when you receive your diagnosis or prognosis, when you have access, that impacts your survival rate. If you have access to a collegiate body of healthcare practitioners helping you, and the characteristics, the biological characteristics of the tumor. And I'm not just going to focus on those elements. I'm going to focus on these first two that are the focus or core of my research. And that could be modified, based on research. Let's think about having access to treatment. We use the database and see how many women have the protection and receive benefits through the funds of catastrophic or entities. So let's measure this in time. Since 2007 and 2016, we analyze the gap. A person can receive a treatment. How many of these patients that don't have benefits or access to the healthcare system receive some sort of coverage due to a public financing mechanism that did not mean that these women had to take money out of the pockets to pay? The gap was measured. It was at 71% when the prevention funds led its budget to exercise and protect these women. So there was a decline to 0.15%. Those are the estimations. So there was an increase in having people or users have access to the treatments. But what happened with the survival rates here? Now, survival was not modified, the numbers there. From 2007, 2013, we had like the same rates of survival, phase by phase, or depending on the phase of cancer there. The distribution or the spread of this chart in clinical phases or staging of cancer in our graph from 2007 to 2016. We observed that the majority of women that received cancer received, a diagnosis of cancer in a very late stages of cancer, very late, very late. If we compare these numbers to other economies or countries, we see the differences between Mexico and Brazil. We achieved a 30% of detection in early stages. In Brazil, they achieved a proper diagnosis of 46% of their population there. And so it's self-explanatory. That's why we know that the survival in Brazil is then way better. Now, to summarize things, what happens in the 10-year analysis? Here we had a guarantee. The guarantee is to treat people even if they don't have rights of Social Security benefits or treatment. The death rate, the mortality rate increased. Survival had reached that plateau. It runs in horizontal, and the likelihood of the incidence, it increases. So that's why the death rate has increased there. This is happening due to the survival has been affected. We increase the capacity that the users have to enter a treatment, but the stages of cancer, this is happening due to the design of the popular insurance agency. For a person to have access to those funds amidst a catastrophic scenario, they should have received an instrument issued proving that they had cancer. So the barrier, the obstacle in that stage was imposed prior their screening. They didn't go to image testing or get those injections or biopsies even. So let's go to the second phase of my narrative today. I was going to say that I'll try to convince you. We're trying to analyze the delay or the lead time in which a person receives all the treatments and treatment. This is the first module. This is what we can influence to modify the latter stages. If we continue having a constant access to those users or beneficiaries, we haven't been capable of guaranteeing access to the users. We have to take care of both sides of all the links or the chain. Here I open brackets, theoretically. What's early detection of cancer? According to WHO, based on the guidelines and books, it's a public domain. That public domain book is in the network. It's object of translation. It's in Spanish. So there's two ways of detecting the initial stages of cancer: screening and early diagnosis or prognosis. What's habitually done, it's prior detection and screening. And they're used to synonyms. And the early diagnostic capacity that we've had has been left for latter stages. In this country, we want to offer the best top of the best for our people. It's understandable, but as physicians or doctors, we receive that education and they educate us to offer the best of the best to the individuals that are the counterparts, the user. So what happens? We want to offer the best technology to the patient, the best medication, irrespective of the cost to all the individuals. But we have not been well prepared or educated to understand the system, the structure, the economics, the budget in the system. How much can we spend on each patient? And as doctors, we forget about strengthening the base or the bedrock of the institution or in that system. What's equally important, we really have to strengthen our capacities to issue a proper diagnosis. What's the difference between one detection and the other? The timeliness, the time before the symptoms appear or when the patient suffers the symptoms. Here you see at the core, at the center, the natural development of the disease. The healthy cells, they transform, and then you have a pre-stage of invasive cancer that you could previously detect with a mastography and screening. And if time delays, then the cancer might go through propagation, metastasis, and cause of death if we don't intervene treating patients timely. What's the difference when we have two strategies? To screen our patients, we have to offer that testing or sampling to all the risk population. That's a blank screening. And you see the numbers in the chart that that general of demography or that universe could be object of the screening. And there's going to be cases in when the result is going to be normal. If we stage cancer, initial diagnosis in early stages, you have people that already have the symptoms. So another frequent mistake that I've observed and I've analyzed based on literature, and I've been to many conferences in a Congress, and we have to use the right tools to detect cancer in early stages through screening, another test. And those, you have to understand the terminology and the meaning of each the terminology. It's not an alternative. It's either we do or execute one task or another, and things have to go in order. And it's a step at a time. How do we take immediate action a step at a time? Follow the process to reach as many as you can. And we have to be very mindful for screening to really have an impact on mortality or death rate at a national scale, at population level. We have to increase, it's a very broader coverage. 70% of the population should be subject of screening and mastography to really have an impact on the mortality or death rate numbers. What happens simultaneously? The majority of the breast cancer, breast cancer is detected when women suffer the symptoms. If there's countries that have screening the population in broad coverage, in the US and the UK, 60 or 70% of the breast cancer patients, are analyzed when they already suffer the symptomatology of it, even if their screening in early stages is higher. In Mexico it's 85 or 90%. Even if in Mexico we screen the population, it's like, no, we have to continue screening, testing, screening. That doesn't mean that you can simply not take care of the patients that have received the proper diagnosis and show symptoms. That's fundamental. Where do we start? We have to start from here. These women have higher risks of suffering cancer than these other groups that we're looking for. And also, we under ethics, that's our duty, it's our mandate. Under oath, you have to pay services to those patients that have a problem. How do we open the doors to other people in our population that are desperately knocking at our doors as well, that are just wandering around, knocking at our door, trying to get a service for months? I'll speak about each one of these elements of the graph to explain what's happening in Mexico. Screening. We have compiled just data, not enough. We do have data, just a little bit. In Salud, this is a survey, rollout survey that's happening at a national scale. We go knocking door to door yearly, and we asked people in the household, have you received a screening to detect if you have breast cancer? That gives us an idea of how we're doing. In 2006, this was a coverage, 17.2%. In Salud is a source. In 2012, 16. 19.6. Pardon. I think that the numbers are, it's the demographics by age group. So it's 40, 49, 50 to 69. The norm was object of an amendment. So we rolled out the survey but we can't really compare because there was an amendment, but there's similarities in the chart. We've included two groups of the population, two age groups, and we measured, and the coverage is almost 29% according to Salud. That's not close to the minimum that's been specified by WHO, that's 60%. In comparing our screening to other countries in the world, it's this. The data is pretty old. We use it to compare what's happening country by country. I mean, we're ranked we're ranked almost in the last numbers according to the American states, and that's a percentage, 60% of our coverage. And screening is very complex. That's another side of our tasks. Just if a patient went to get an image or a mastography, okay, they went through it, yes, no. Screening is a process. It starts with the initial snapshot or screening of the patient. And the rest of the steps to achieve the proper diagnosis, if we don't go through all the phases, what's procedural to obtain a diagnosis is like if you wasted your money, and the budget, if you don't go through all the phases of obtaining a diagnosis. We don't have recent data, but they were just discussed by Ale. What you submitted in your presentation, Ale, was great. I would like to see the cascade effect there too. But here, only 16% received, or 16% of the patients received contrast or image testing, and 44% out of these received some sort of biopsy. Major problem. I know that here, we haven't captured all the data. Not everything is captured in the historic data of the SICAM, but this is the data that I found from the sources, and it's reliable, objective data. But my colleague here at the auditorium said that she has other data, different data. But here, let's see on this side how we're doing. What's been proven based on findings, this is a meta-analysis. The longer it takes for a patient to receive surgery to cure his or her condition, or even the chemotherapy after surgery, the longer you take, the higher the death rate or mortality due to cancer. And there's findings and evidence. Everything that's highlighted in pink is breast cancer. There's clear evidence. If you add an extra 4 weeks to delay a patient's treatment, you add up 10 deaths per 1,000 women. How were we doing in 2010? In 2010, I measured what happened with 2 Social Security institutes in Mexico, Gynecologist Ward number 1 and the IMSS unit of oncology, the Mexican Institute of Cancer, and other authorities. I measured this in the interval. I measured 210 days in the chart, around 7 months. So a patient identified he or she had a problem. They started the treatment. That was the time lapse. And the first time the patient received the physician's admission to the hospital, it took them like 4 to 6 months to get more information. So habitually, in contrast to what we think that the patients are the ones that don't go to their appointments, and they delay, and they're in denial, and they're fearful, and they're ignorant. And the patients, and I hear all these adjectives that are used to classify women, and I'm on this every day, and I want to identify the motives, the reasons why patients don't reach these institutes. But let me say, yes, there's women that might delay, from 0 to 65, 20% of the women or patients delayed. They had certain conditions, and there's patients that took them 2 months to go to the institution or the hospital. They don't delay. Some women don't want to delay their access. They just face the systematic labyrinth that they have to go through to try to have access to the services. This dates back to 2017 in INCAN, or the National Cancer Institute in Mexico, and other healthcare institutions. I'm comparing the interval, that window until the patient receives diagnostic data, from the first doctor's physician's appointment to the final diagnosis. Here, I compare the patients that used a private service or the private healthcare institutions versus the ones that went to the public healthcare institutions. They had the right to access the closest healthcare institute. What we've observed, the time frame, the horizon is shorter if they go to the private institutions. We knew that. I mean, that's why the people who suffer this go to the private healthcare system, but we hadn't measured it to really try to see the difference and compare, contrast it. We see that there's a decline or cut in time to obtain their physician's appointment to get their x-rays. They go to the private healthcare system to obtain a physician's appointment, to get their mastography, to get that ultrasound. And if they have enough budget from their pockets to pay for their biopsy, and that's when they spend so much money that they're resourceless when they approach the public healthcare system that they had access to, or that they could have obtained their services from. We know the path, the critical path of patients that suffer breast cancer. We can analyze the symptoms and obtain screening. When we find normalcy, we can go to the phase of diagnostic procedures to assess the clinical history of the patients. We have x-rays, tissue sampling, pathological tissue or lab execution of, and multiple disciplines that are involved. What happens here with breast cancer? Based on my research and on my findings, I'll try to succinctly explain what I've observed with the collective, well, multiple disciplines. 85 or 90% of the patients go to the symptoms. During screening, the patient in that first step, that just tickles, the burden of the condition or the disease at the beginning phases. There's so much to do. Then there's follow-up problems, quality control issues. So we're not really tackling or affecting or impacting the monster as we should. The majority of the patients to be part of that next step of the screening, the first phase, the first physician in the healthcare institute is leading us to analyze, okay, the patients are going to the private sectors, the private physicians, and they're going to just the practitioners in drugstores. That's the first physicians of contact for the majority in the population. Then we fall into this nebula. There's like a major gap. It clouds up what's happening with the patient. If the patient was fortunate enough to go to the physician whose lights turned on and he went Eureka, okay, you patient, you need to go get your x-rays, your images. We need to scan you. How much does it cost? Where do I go, doctor? And then the patient has to save money. They obtained their x-rays or images, and now it was wrong. The quality was not right, and it was mistaken. And then they have to go get an ultrasound, and the patient has to come and go to many places. The first world countries, in the same center where they get their physician's appointment, they get the mastography. If it's abnormal, they go to ultrasounds or any compilation of images or x-rays that are required. In that same center, immediately you get the biopsy and you get your results in a 10-day term. Lastly, what happens if oncology centers should take care of only the treatment? And it wasn't just me. In these centers, they should just take care of providing the oncological treatment. I'm not changing it here, sir. What we're observing is that how do we approach and obtain diagnostic data? So sometimes during the diagnosis in oncology, we consume more time to issue diagnosis. We are wasting our human resources, material resources. We're working with our healthcare practitioners and on the same thing double. So the resources or human resources are scarce, and we have to use the equipment twice because things weren't done right from the beginning. That's what happens in summary. And another point, we can't mark a difference between benign or positive conditions of patients that have cancer. I mean, and the time it takes for someone to issue a diagnosis data, it's like they're both queued. Patients that go for screening are queued in the same line. Those who have cancer, but a cancer diagnosis that's positive, and those who have cancer and have other phases and stages are queued in the same line, and we can't accelerate or, the diagnosis for them. You know, this frequency in this module, it's like, how frequent is cancer in those who have symptoms? And those who read those, who went to the network or healthcare practitioners and went through screening. You know, I'm here as the voice of other patients. Alice said she doesn't like to talk about just proportions and numbers. She talks about it's people. I think about the people. It's a subject, it's a person, and we sometimes forget about what the patients go through. I mean, I've documented the problems and I have documented the numbers, and there's a lot of cases in where there's medical mistakes, when people have to sit and interpret the data and go through peer review. But this is and I quote the patient's case. This patient received a treatment three months after she should have received the treatment. In the healthcare unit, she was told to just go back home and take like diclofenac, that's like Tylenol, ice, and just medication. And then this patient went back to the system with a lump in her auxiliary section. She goes to another physician, to Farmacias Similares, a Mexican drugstore, and they go, I mean, they treat them humanely with quality. You know, Armengol, you know, our doctor before me just said that what we would like is for a system to really be welcoming, to have clear priorities on the day-to-day practice, where we're all doctors and humane enough to treat our patients kindly. And if we're not humane when we treat our patients, they suffer it, and they avoid, due to suffering, they avoid going to the healthcare system. When we as patients go to the healthcare network, they see us as undesirable humans. The physicians don't even look at us. They don't even treat us. A doctor in the public healthcare system just looks at us. What are you here for? What do you want? So I prefer to go to the private practitioner to improve the quality of the service. But then you think, how much money do you need to save your life and go to the private sector? I mean, the private sector is seen as better because they're treated as humans, as people. I mean, there's competition in the healthcare field amongst physicians, but the patients, you know, really don't know what type of services they're going to be served, you know? How do you judge them? I mean, us from this side as doctors are judging them, looking at them, or simply ignoring the symptoms, telling them that what they're suffering is not important. Another point. This is a quote from a woman from the indigenous population who gave us her reportership. It's like sometimes because their profession, they feel they're superior, they mistreat us, and I felt abused. We've all experienced abuse from doctors. They're mocking us, and there is a collective of women, and I quote this woman from indigenous communities. So the doctors, you know, are making fun of us. When I went with my kids, they examined me. It was horrible. They just put their hands inside of me, and I don't know what happened with my presentation. It simply shut down. And these doctors laughed at me and they mocked me. So I'm asking myself, why are you treating us this way? There's so much to do. I mean, you can't dehumanize the services and the way you treat people in the healthcare system. I mean, the patients should come to the institutions in early stages, but they're not wanting to because of that. Solutions, feasible solutions to be discussed. I mean, we could all brainstorm here about it. But let's shed light at an international scale. It's not one solution for all the countries. It's not a tailor-made solution. It's not the panacea. We don't have maybe enough human resources, material resources to have like all this, the numbers correlated. But I thank you all, and I thank Dr. Armengol, the representative of the Mexican Institute and the system and the structure. There's ways to exercise the budget. This has been published last year. It's been analyzed in 3 layers. There's 3 pillars. And we have to react. First, we have to foster health for early detection purposes. In early stages, we want females to approach the institutions, to know their body. It's very important. Let's not just stop there, because we start those programs, and I've been in this field working since 2007. And since 2007, it's the same narrative. I hear the same things. Let's educate our patients. Let's train our patients to really examine themselves. Let our patients visit the institutions. But there's a couple of extra pillars which are a priority, that are part of our duties and our mandates as healthcare system elements. Timely, full, thorough diagnostic data. There's metrics, so the metrology from WHO. There's countries that even take more time to issue diagnostic data in comparison to Mexico's capacity, but we have parameters.
And it starts running when they go to the consultation with the general physician for the first time, and we have 60 days to complete the diagnosis. And finally, access to treatment, comprehensive, which is to say multidisciplinary and complete and timely and in the proper way. We currently know that there is a lack of radiotherapy, and the wait to start the radiotherapy has to wait for months, and many of them are not working. They are broken. There are many issues, and we continue telling the patients to explore themselves and to go to their physicians. Yes, of course, but let us then guarantee that when they come to us, we treat them in a humane way. We know where to remit them. Not only is telling them that they need a mastography, the physician in every health center needs to have a support from their health system to know where he needs to remit them, that it is close to them, of quality, that they don't have to spend so much money. And if it is for free, that is even better. We know that we have general coverage, universal coverage. So we need to empower doctors to do their work. An important model of the UNEMs of MECAM, we use them to do diagnosis and not to do more screening until we put things even. And well, I want to also leave you another international reference, this initiative for the memory global health that they talk about an implementation of the stages of things. And when they talk about the guidelines of early detection, they say, okay, it could be if you can do it, do a screening, but before to do a screening program, make sure that you have these 5 things well established. That is to say, that you can guarantee access to treatment, that you can diagnose the disease by tact, that you have critical routes of reference so that the patients go quickly to those places, that you have your diagnosis or your imaging studies and your staff well trained doing things with quality, and of course, you have guaranteed the systematic updating of your imaging equipment. That it is not acceptable way to continue to have imaging equipment which have expired occupying dead space, and that it is not acceptable that we don't pay maintenance policies and they are broken and they stay there for months and broken. That we start to be serious about what we want to do before doing mastographies and saying that we have made 100,000 mastographies in a certain state for proselytism. Finally, let me tell you about this research center that we are creating. We receive funding from the National Institute of Cancer. It is an alliance among these institutions that you see listed, looking for a center to empower the research and science of implementation for the control of cancer. And together with that center, we have a breast cancer project that we are starting in the health services in Nuevo León with these 3 goals, with a goal to lower the diagnosis time, explore barriers for the rapid diagnosis, design the strategies directed to those barriers, and finally, assess the effectiveness of our program. In summary, what we want to do is strengthen how, from the first level of attention, with integrated routes of attention, the patients can come to the diagnosis clinic as soon as possible. Why Nuevo León? Because we have an ONEM from EDICAM that works very well, where we do everything, the diagnosis approaching in the same place, in the same visit as far as possible, with exception, of course, of the pathology interpretation that delays 2
esperamos
weeks.
que si
But we hope
demostramos
that
que
if we can
efectivamente
prove the
esto pueda
effectiveness of
funcionar
this,
como un
it
modelo
will
más
work
factible
as
de
a more
implementar en nuestro
feasible
país,
model to be
donde
implemented
podamos
in our
establecer
country,
centros
where
de
we can
diagnóstico de
establish
altísima calidad
diagnosis
en
centers of
puntos
high quality in the
estratégicos del
strategic
país
points of the
y
country,
fortalecer a un
and
primer nivel
strengthen
de atención
at
que
the
pueda
first level of
referir a los
attention that
pacientes
can remit
sintomáticas
the
a estos
symptomatic patients to
centros
these
para
centers
reducir los tiempos
to
y
lower the
entonces reducir las
times and
etapas
lower the
y ojalá
stages. And of
así
course, we hope
mejorar
with
pues la
this
mortalidad
to
por esta
improve
enfermedad, siempre y
to
cuando
the
no se nos caiga
mortality
el
due to
acceso a
this
tratamiento.
disease, whenever the
Si
access to treatment
solamente
does
hacemos
not collapse. Because if we
diagnóstico más
only
temprana,
do
no va
early
a servir de nada. Se
diagnosis, it will
necesitan
serve nothing.
ambas
We
cosas
need
a la
both
vez,
things
todo el tiempo,
simultaneously, all the time,
acceso y diagnóstico.
access and early
Gracias.
detection. Thank you.
Muchas gracias.
Thanks a
Bueno,
lot.
ha hecho entrega de su reconocimiento
Well, we have given her her token of appreciation
en
for
este
her
primer
participation in this
Congreso Internacional de Abordaje
first International Congress of Interdisciplinary and Integral Approach on Breast Cancer. And now, dear conference speakers, there's been a change of last minute, so we invite Dr. Yolanda Villaseñor Navarro to take the floor to give her presentation titled New Expectations of Screening for Early Detection Experience in INCAM. I would like to highlight that Dr. Yolanda Villaseñor is Deputy Director of Ancillary Service of Diagnosis and Treatment at National Institute of Cancerology. She is an expert in radiology and imaging with subspecialty in oncological radiology, also professional of high level and research professor at the National Autonomous University of Mexico and at INCAM. She has presented in different national and international forums. And well, we give you the floor. Thank you very much.
Me disculpo por la
And